Alright, welcome back to Midnight Med. This video is on gastroenteritis. The classic presentation would be a patient presenting with fairly non-specific symptoms like abdominal pain, cramping, bloating, vomiting, or diarrhea. The patient may have one of these symptoms or many of them. In more severe cases, there may be fevers, bloody stools, significant weight loss, abdominal tenderness, guarding, or rigidity. It's always important to consider recent travel, especially to tropical regions and developing countries, as a key risk factor. So, what exactly is gastroenteritis and how does it develop? Essentially, it's an infectious disease where viruses, bacteria, or parasites cause inflammation of the stomach or intestines. This inflammation is responsible for the symptoms. Transmission of infectious agents is often through contaminated food and water, or by the fecal oral route. Key pathogens include viruses like rotavirus and norovirus, which are overall responsible for around 70% of all gastroenteritis. Also, bacteria like Salmonella, Campylobacter, which is associated with subsequent Guillain-Barré syndrome, E. coli, Vibrio cholera, Yersinia, and Clostridium difficile, which is associated with antibiotic overuse. And overall, bacterial causes are responsible for 15 to 20% of all gastroenteritis. There are also parasites like Giardia, Cryptosporidium, and Entamoeba, which are responsible together for about 10 to 15% of all gastroenteritis. Note that I've italicized the pathogens that are commonly associated with travel. The key risk factors for contracting gastroenteritis include poor hygiene and sanitation, so lack of hand washing, a contaminated water supply, eating food raw, not refrigerating cooked food, traveling to developing and tropical countries, being unvaccinated against some diarrheal diseases like rotavirus would be a classic example, and the use of multiple antibiotics, which is a predisposing factor for the development of a Clostridium difficile infection. Some of the following red flags might suggest something more significant, or perhaps even an underlying cause that is distinct from a simple infection. Fevers, weight loss, and signs of dehydration like decreased skin turgor, altered mental status, tachycardia, and hypotension might suggest invasive bacterial disease. Blood or mucus in the stool, in addition to high-grade fevers, might be reflective of something like inflammatory bowel disease underlying the presentation. A recent hospitalization and antibiotic use raises our suspicion for Clostridium difficile-related gastroenteritis. The aim of investigating a presentation with gastroenteritis is twofold. Firstly, to exclude more serious causes, and secondly, to guide management. Base investigations would be a full blood count and a white cell count to assess the presence of severe disease or potential complications. In most cases, these findings will be unremarkable, although there might be a mild leukocytosis, so an elevated white cell count. However, a high white cell count might reflect an invasive bacterial infection, and low platelets might indicate the onset of a complication like hemolytic uremic syndrome. We also want to assess electrolytes urea and creatinine, as they will point to potential electrolyte disturbances and acid-base derangements that may potentially require urgent attention. In severe dehydration, the EUCs might reveal findings similar to an acute kidney injury. In those with systemic symptoms, blood and stool cultures will be useful in determining the potential cause of their symptoms and will help direct treatment appropriately. Lactoferrin, a sensitive marker for fecal leukocytes, can be tested for as well if there's a suspicion of inflammatory bowel disease. Management of gastroenteritis is usually supportive because cases are generally self-limiting. In uncomplicated cases, we focus on hydration, rehydration, and bowel rest. We generally rehydrate with oral rehydration solutions first, and then can step this up to intravenous fluids if the patient is unable to tolerate oral. A simple diet may be recommended as well to ease the burden on the gastrointestinal tract. Antiemetics can also be used to control the nausea and vomiting. In severe cases of suspected bacterial gastroenteritis, empiric antibiotics can be used. Most commonly, we use fluoroquinolones and azithromycin. However, particular pathogens have particular antibiotic susceptibility profiles to be aware of. For example, fluoroquinolones should be avoided in the case of Campylobacter jejuni because of resistance. Further, Vibrio cholera is responsive to tetracyclines, and these should be the main first-line treatment. Clostridium difficile infections are managed differently because they arise as a result of a bacterial overgrowth subsequent to heavy antibiotic use. The offending antibiotic agent should be stopped, and metronidazole should be used in mild to moderate cases, with vancomycin used in severe cases. Parasitic infections with Giardia and Entamoeba are best managed with metronidazole, while Cryptosporidium infections are best managed with supportive care. That's it, so thanks for watching. Remember to like, subscribe, comment, follow us on Instagram for more, and we'll see you in the next video.